So, hi everybody. So this is a workshop, so I'm just going to do a very brief presentation about some of the work that we've done around telehealth over the COVID period. And I should say, my name's Lesley Platts. I'm the designated clinical officer for Islington. Okay, so let's get going. Can everybody see the screen?
I can definitely see it.
Okay, so we'll get going. Okay, so what is telehealth? Telehealth is a delivery of healthcare services where patients and providers are separated by distance. Telehealth uses ICT for the exchange of information, for the diagnosis and treatment of diseases, injuries, research evaluation, and for continuing education of healthcare professionals. Now, up until last year, probably never even heard of telehealth. And suddenly now we're all experts. And you can see nationally or internationally how many areas across the world do use telehealth or forms of it.
Sorry, Lesley, just to stop you there, I think some people are struggling to see because it's quite small. Is there any chance of putting it into slideshow mode?
All right, yeah.
Thank you.
Is that better?
Yeah, that is better.
Okay. So, 2020 in March, everybody went mad for Zoom. We were told basically overnight that there was no face-to-face assessments or interventions for non-essential clinical work. That in itself was complicated to decide amongst all our caseloads about what was essential and what was non-essential. Lots of arguments about that, and I'm sure all of you did. The workforce was diminished and suddenly everybody was working from home. So again, making life in terms of any kind of clinical work or direct work impossible, and nobody could go into schools or health centres. So again, we had to work very quickly around IT, and a big question in our organisation was, where was all the laptops? Suddenly nobody had any laptops, and I didn't understand what RDS was. Maybe some other people do now, but I do now because it's about linking up with PCs into your home laptops. But that was a real complicated start to COVID for everybody. And that was only week one. Suddenly digital platforms, access to RDS and laptops became like gold dust, as I'm sure it did for everybody. Week two of COVID, we had Zoom and more Zoom, and then we had something called Teams, and then we had Attend Anywhere, and then we were told we weren't allowed to use Zoom because of the IG issues. So it was a really crazy time, and I'm sure everybody experienced that as well. Overnight, we seemed to be discussing digital platforms. And between us all, we started doing literature searches about efficacy around telehealth, how to do telehealth, how we could do diagnostic online assessments, which we started to pilot, which was the Vanderbilt, which I think I spoke about at a previous meeting. How do we do clinical treatment sessions online? How do we run training for groups? And then what's all this information governance as well, about working from home, about connecting with people. Suddenly we had to buy licenses, write business cases in order to use particular platforms, and we set up some pilots. Although telehealth wasn't new, it suddenly became one of the most important platforms that we had in order to communicate with families. And then a new word, digital health and data poverty, along with food poverty. And this was a real issue, particularly working in inner London, where we have a high level of deprivation. And a number of families did have access to a laptop, but they only have one between, a family of 8. And the data poverty of it, people not having been able to use Wi-Fi or being able to stream some of the video links on the telehealth were all a bit of a nightmare. And there's still not enough laptops. In fact, I spent most of my day yesterday chasing laptops and ordering new laptops for everybody, because as we continue to still work from home. Some of our schools were able to give laptops out to families, but often people in the early years were missed, and those families, particularly those with new mums, weren't able to access some of the parent groups because they didn't have access to laptops. So it became a really big issue. And then there was more governance. We had our IG department, calling me all the time about how many staff were using digital platforms and what type of platform they were using. And then working out, does this actually work? And how can we measure whether we've been successful in supporting our young people, children and young people over this time? So we established something called a telehealth steering group. And this was really all the clinical champions over we work across 3 boroughs in North Central London, got together and started to think about how we could formalise the use of telehealth and how we can people in our organisation to use telehealth effectively, and also to look at measuring the outcomes from using telehealth with the children, young people and families that we were working with. So we set up the steering group, and our terms of reference were really around us as a group exploring the range of clinical platforms that were available, and looking at whether they were good value for money, how much licensing cost, how much streaming it cost for families, whether it was family friendly, whether it was accessible. We looked at whether we could use them for diagnosis, and particularly around autism, as everybody is aware that there's a huge backlog of children with autism requiring diagnosis as well over this time. Then we looked at a variety of different areas of clinical outcomes, including satisfaction surveys and clinical impact, using things like, well, we use something called the patient specified functional scale, which is like a GAS goal, and seeing whether we've actually made any improvement. Looking at whether we can deliver group consultations. So most of us in the NHS were told we were only allowed to use Attend Anywhere, which is not very useful for group consultations or for delivering training. So we wanted to look at different mediums as well. We also looked at how we could improve the communication systems in telehealth, so how we could use interpreters, how we could standardise and write standard operating procedures around how to use the telehealth systems. We looked at some of the public health areas, so some of the barriers, as I've already mentioned, around accessing telehealth. And we did quite a lot of literature review, actually. We looked at lots of articles, particularly from the colleges, around efficacy and evidence around innovations. And then, of course, we looked at safeguarding as well, and looked at how we could ask questions and identify any safeguarding issues whilst we were online with children and young people. And we've taken we've done a number of reviews looking at outcomes, including parental satisfaction with remote access and usability in particular, clinical validity of diagnostic tools. So we've done some trials with the Vanderveld online and compared that with our use with the face-to-face and using the ADOS. Patient specified outcomes so that we could really see whether the child had made any progress. And there was a mixed picture, really, and some staff, we also did survey our staff as well, and some preferred online and some preferred face-to-face, and that was a very similar picture with our parents. Some of our findings from some of the research was that the use of coaching techniques actually helped parents feel that they could help their child more and had a better understanding of their child's needs, and could really see progress with those children that were using this method. It seems to work best when we discovered that it seemed to work best using telehealth when we already knew the child. So really good for things like reviews, or when we've done one face-to-face and then we've done a follow-up using telehealth, that seemed to be much better because that engagement had already occurred. Diagnosis, a number of families, and this was a really interesting finding, felt that actually receiving the diagnosis online was much more comforting in their own homes than it would have been in a cold, barefaced clinic. So we've had quite a lot of conversations about actually this is something we would definitely think about keeping. Some children and young people themselves said actually they preferred Zoom because they didn't have to travel to a clinic or feel overwhelmed when they were in a clinic environment. And again, that they could be in the comfort of their own space when they were accessing therapy. Group consultations, parents reported that they could put a lot of the techniques straight into practice and that they could practice there and then in their own environment rather than coming to a clinic base and then having to travel home. And then by the time you've got home, completely forgotten about what you've just been talking about. And another big area was that it really supported working parents and dads. And they really liked the fact that it was much more flexible. They could pop out for an hour sort of over their lunch break and join sessions, and didn't feel that they had to take, a significant time out of work in order to be able to access some of our services. So there were lots of really positive findings. Now, I'm not going to go through all the negative findings, and of course they're almost contra to everything that I've said in terms of the positive findings, but that's kind of what you would expect. But one of the things I would like to leave with is that there are lots of evidence around using telehealth. We didn't review 600, but there are around 600 public articles when we did our big literature search on this. And there's lots of evidence about high patient and staff satisfaction with using telehealth. There's not a huge amount of evidence around cost effectiveness, which of course is what our organisations are always looking for. And that also families seem to want a mix of face-to-face and remote. So these are the questions that I wanted to ask to the group, and this is the kind of conversations for us all to have, is what have been your challenges in using telehealth, and how have you overcome them? Which elements do you think we should retain after COVID, and what's been your experience? And have you done any outcome measures? What are the barriers to remote working and how can we remove them? Issues around digital poverty, issues around families that need to use an interpreter, and have you established a telehealth steering group? Because I think for us, that's been the really one thing that's helped bring us all together and share our learning and experience over this time, and to hopefully improve the quality of the telehealth services that we will continue to use after COVID. So that was the presentation, and I don't want to leave it up because I can't see anybody. I don't know if I can put it as a little small thing in terms of the questions. But I really want to open it out to everybody because this session is about sharing our experiences, and they're just my ones. So maybe we could...
Sorry, I'm happy to put up the questions if that helps.
Okay.
And then there's a question in the chat from Natasha. What has been the experience of families whose first language is not English? Have interpreters been used? How has the language barrier been overcome? I can see it on the key questions. I'm interested in experiences. So that might be a place to start.
Yeah. So yes, we have used telehealth with people whose English is not their first language, and we have used interpreters. So we have an interpreting link that comes into the clinical session, and they do the interpretation. Often we've met previously with the interpreter, particularly if we're going to do a diagnosis, so that we've given them a bit of a prompting about some of the language and some of the kind of conversations that we'll be having in the meeting. But yeah, we have. Has anybody else used interpreters? I mean, should we just get a bit of a straw poll about who's using telehealth? Yeah, we've used interpreters with the link. That's what we're using. Can people not talk? Can they not?
They should, if they want to, they're absolutely welcome to.
It'll be useful. It'll be useful to know who's here as well.
Hello, can you hear me?
Yes.
Yes, I'm Dr. Cole. I'm a DMO for Walsall. And we have also started doing tele consulting, and we don't have this fancy name for it, but we started, I think, in the second week only, because we knew that we had a long wait list and we could not just sit and not do anything. And it has actually worked well. I think, as you said, yes, if you don't know a child, then it's become a bit tricky. But what we did is that we, as a consultation, split them into two parts. So one would be a telephone consultation with history, gathering history and information from parents, and then we would do a more briefer face-to-face appointment. So, but a lot of follow-ups, especially ADHD medication follow-ups, sleep follow-ups, we could do very easily on telephonically. And we had a very good community nursing team who used to do our blood pressure and weight for our families, for our children on ADHD medication. So it did work well. Did
they do that face-to-face then?
They used to go to the home visits. They did home visits for us. Yeah.
Ah, okay.
So that really helped because we were struggling on how to do that. Bringing them all to hospital was not a good option. So, but that really helped us with carrying on with the ADHD, waiting list, and we could carry on that work. The only difficulty, I think, is, I don't know, with the EHCP assessments, because some of these children were not known to us, especially younger children. Because most of the children who with AHCP are picked up by our CDC team or TAC team, but the ones we had not picked up, so we kind of had a bit of a lost opportunity there. We could not see them face to face. So what we did is that we did a telephonic consultation first, and then we drafted a report so as not to kind of have that barrier for the EHCP plan, but then added an addendum to say that we will do a face-to-face consultation and add on that report, so that we don't have a big backlog of EHCPs in place. Yeah, that's how it worked for us.
Okay. And will you continue?
Yes, I think that's another consultation we're going to have soon. That looking in future, I think so. It has its. I think what we also found is that we had less DNA rates.
Yeah.
Especially initially I think we had some DNA, but by the end of normal clinics, one of my telephonic clinics have 100% responses. So I think it does work well, and I think we'll have to choose. I don't think it will be universal, but to choose our parents and our young people who would really benefit for this from this service. I think it is therefore is going to stay there in some form or the other.
And I think you made a really good point there about DNA. We also found actually our DNA rate was significantly reduced. Certainly in the beginning, we had lots. The DNA rate has started to creep up again now with using telehealth. People have sort of got a bit bored of it, I think, but it definitely did help. And you know, the background of telehealth is that it was developed in places like America, where they've got vast geographical areas to cover, and that's why they've had to, for many years, they've been using telehealth around diagnostics and intervention, because it's just too far to travel to specialist clinics.
Yeah, it makes sense.
Yeah.
I think for young people it has helped because they don't want to come to clinic. I think the young teenagers, I think I think it will be there to stay, at least for that subgroup, definitely.
Yeah, we've even used it with children with MSK issues, telehealth program, and we're always never turning up. So now they can do it in their own bedroom, and they can just click in when they want to have an update on their exercise program. Actually, that's been really good. Susan, you seem to be flashing.
But do you have any questionnaires that you've done? Because I would like to do this. I've not done any feedback from parents, but that would be something I would really like to do and see what the experiences is.
Yeah, send you one of our questionnaires. I mean, we use ICAVIVA, so it's an online system. Which is generated after the consultation that they get to do the immediately online feedback.
Okay.
Yeah,
that might be something. Yeah.
Ask the family and friends test. Tick.
The standard. That's fine. I think that online thing is good. I think that immediate feedback would be good, actually. People forget, isn't it?
Yeah. So ICAVIVA is a new Meridian. If you were using Meridian, if you're using an online.
From the e-clinic, and I think our therapists use something different. I think what is it? Accurate, something else. Some different.
Oh yeah, there is
accurate something. Yeah.
Yes, yeah.
So I don't have the experience of the other one.
Yeah, I mean that's just what our organisation has purchased. So we use that. We've been using it for a long time. So it's always been linked to our clinics, but it's now linking it. How did we link it into Attend Anywhere and into Teams and in? Well, we're just trying at the moment to link it into Zoom.
Yeah.
Did anybody have issues with Zoom? Because that seemed to me like that was like a constant debate, especially across London. We couldn't use it. We could use it. We couldn't use it.
We never used it, actually. We never even started with Zoom. We had this something called e-clinic. I don't know what system that is. Something. Yeah. So we used that. And Accurus for the other teams. So we never used Zoom. I'm not sure whether, because some of the programs, like we used to have this courses that we deliver online for parents, they might be using Zoom, but I'm not sure about that. I'm not sure.
Well, we're doing 2 pilots around the use of Zoom compared with the use of Teams for group consultation. So I saw somebody in the chat just here said that they weren't allowed to use Zoom. And we weren't allowed to use Zoom, so we did write a business case, and we looked at all the security around clinical information, and we've bought a pro license, so you have to have a sort of higher license in terms of information governance, and we've been allowed to use that over a 3-month period to see whether it's sorry, getting another message through from back there.
To see
whether see which platform people prefer to use, because our clinicians definitely all wanted to use Zoom. It's very flexible, it's easy to run groups, you've got breakout rooms, has backgrounds. There were lots of reasons why they wanted to use it, and had also almost immediately in our area overnight started using Zoom as their first platform, mainly because a lot of people use Zoom in their personal lives. So actually to transfer that, it was really quick for a lot of people. So yeah, we had to do a big business case for it to get it approved, and yeah, it has been approved now. So it'd be interesting. I'd be more happy to share our results. We've done a comparison as to which is a better digital platform. We've also looked at this, we've also looked at the cost of streaming on the different platforms, and Zoom is actually slightly cheaper to video stream than Teams. So that was one thing. And we're now looking at some other platforms to see whether we can find platforms that are even cheaper to stream from.
Okay. I haven't thought about so much.
I know, if you'd asked me this 12 months ago, I wouldn't have a clue what you were talking about. And suddenly I'm an expert. Well, I'm not an expert. I'm definitely not an expert. But I'm definitely very interested. And interestingly, you know, the 10-year plan was, for us, was around moving all our outpatients out of the hospital into the community, which for us happened overnight as well. And a big part of that was being able to use digital platforms, because we didn't have enough space for people even if they wanted to run clinics. So it's going to be a really important thing for us going forward, that we have a blended offer of telehealth, but we only want to use it if we know that their evidence is there, that children actually benefit from using it and show outcomes, compared with seeing them face to face.
Have you managed to use telehealth in a school setting, as a school clinic?
Well, the school clinics are, they're not run in a school. If they're in the school, they're generally seeing the child.
I'm also doing from home, but I was thinking whether
they do training in the schools on telehealth. They use it for that kind of group consultation. Not with, I don't think that anybody's using it with individual children. I don't know. I'm aware there's lots of other people in the group. Is there anybody else that wants to add anything? There were some things in the chat. We're using it in schools. Do you want to tell us about your experience, Susan?
Yeah, I think some of our staff are using it. I'm not a practicing clinician. So I am not personally using it, but I know that some of our therapies are using it with schools, rather than going in. Some of our schools are reluctant to have more than one therapist in at any one time. So some of the consultations, certainly speech and language, are using telehealth. Probably more so than physio and OT, because those children needed to be seen, because they haven't been seen since March, some of them. But one of the other questions that I wanted to ask you, Lesley, was around the ASD. I know that you're using the online ASD. Now, I took that back after a previous session I'd been on with you.
Oh dear.
And so I took it back, and our team was saying, oh, but that doesn't meet NICE guidance. Do you know if it does?
That's not true.
Okay.
Yeah, we've done quite a lot of work with the Vanderbilt. In fact, I've got a whole presentation around how we've been using it and the efficacy around it, and our outcomes, and some of the fidelity work we've done to see whether it links up with the ADOS. So I'm more than happy to share that. Or Nicole, one of our DMO, actually did a presentation nationally, actually. I can't remember who she said she was doing it to, but we put together a presentation around all the work that's been going on around the Vanderbilt. And it's quite 50-50. I think some of the very complex children with autism, it is really difficult, and we wouldn't use it with those children. We would continue with face-to-face, and we probably do about 50-50 at the moment, so online and in clinic. For the ADOS part of it, all the other parts, you know, collecting information, pre-history gathering, all that can be done online. But certainly the diagnostic tool part is, we feel, has got some good evidence that it's effective.
Yeah, it'd be great if you could share that. That would be really helpful for us to move it forward, because like everywhere else, we have got huge waiting lists.
Yeah, I mean, maybe we should get Nicole to come and do a presentation to one of the next CDC events, because she's got a really good presentation, and she's got a medical student working on looking more in detail about parents' experience of using it, and how they felt about going through the diagnostic process online rather than coming into clinic. Because certainly the majority during the first wave of the pandemic were all done online, and then since then we've done a blended offer.
Okay, thank you.
We've got a question from Jeff in the chat. Is anyone using ASC assessment with older children or young people?
We have only piloted it with young children, and the Vanderbilt is only for young children. It's not suitable for the over 3.5, 4, so it is for very young children, although they are developing the next module, which we will look at when that comes out. But some people are using Helios, certainly in North Central London. I think Barnet is using Helios, and we're part of the mental health collaboration. Some of our mental health colleagues in CAMS are looking to trial Helios, and I think Cornwall did a presentation on Helios a while ago, but it seems to me like it's very language based, and you have to have a reasonable level of cognition in order to be able to engage with the young person, not the person doing the assessment, the person you're assessing. Although probably both, actually. Is anybody else using anything for the older children?
No, not yet. No.
No.
The Helios is more of a more able children, I think. Yeah, more able children. Yeah.
Helios is for the older children and more able. Yeah.
Forgive me if we've already covered this, but there is some stuff in the chat about resistance to accepting remote diagnosis as valid because assessment instruments are not standardized for remote use. I don't know if you've covered that yet.
No, I haven't covered that, and you're right, there are definitely some families, and one of our criteria for using an online diagnostic tool is where the parent is at in terms of understanding their child's needs and whether they're expecting a diagnosis of autism. So certainly some of our families are already been reading up on autism and are using that word around their child, and they would be the children that would be prioritized. That those families we have used it with, but yes, and that's one of the things that this registrar is looking at, is about parental acceptance. And certainly now, since we've had the blended offer, we did have some quite clear feedback from parents saying, no, we want to be seen face to face. We don't feel that it's appropriate to do it on telehealth, and luckily that's been fine, and we've used PPE, and we have continued on with that. But I think it really depends on where the parent is, and also maybe partly to do with whether they've already met you before as well. And don't forget, most of the diagnoses around autism, yes, there are standardized tools, and the Vanderbilt is standardized for the ADOS Module 1. So we would say that it is acceptable, but there is preparation to do with the parents before the assessment, and to make sure they have the right tools and access to the right tools and play activities. But also we gather a lot of information from other child, so it wouldn't just be around the MDT assessment, it would also be around what they've been doing in nursery. Have they been accessing nursery? We'd be gathering all that information as well. So even if they've got a health visitor, we'd be gathering information around their observations. So it's not a one-off event, giving a diagnosis of autism, as I'm sure all of you know that. So I hope that answers that.
We seem to have a hand up from Susan. I don't know if you still had a question, Susan.
Sorry, no, I need to put it down.
Are there any other questions? Can I just get a bit of a show of hands about who used telehealth over the COVID period? That's Susan. Well done, Susan. So not all of you then. So I'm quite interested as to what you did use if you didn't use this kind of medium. Actually, there was a question in the chat using telephone rather than telehealth. I saw that came up near the beginning. And yeah, we did do some telephone consultations, but actually, I think you're right. I think actually videoing and seeing the family, seeing the environment, seeing the child within that environment is really important. So we were quite keen that it was video linked rather than phone. Certainly in our people services preferred WhatsApp. I don't know if anybody else used that, and that was a medium that was used, because often people just have their phones as well, so it's easier to use that rather than you know, trying to do any other kind of telehealth on a telephone is pretty difficult if you haven't got a laptop. Okay, is there any other questions? If there's any questions in the chat?
Haven't spotted any further questions in the chat.
That's the case, then maybe people can go off and have a little break before the next. We have to log off and log back on, do we?
We do. So from here, you should have a second link to the second workshops that you're all going to, which from the last update should be starting at the original time of 12:30.
Oh, brilliant. So I can go and have a wee.
Yeah, exactly.
Okay. Well, thank you for your time. I hope you found that informative.
Thank you.